we were very excited to present long-term follow-up of our multicenter phase 2 trial of Zanubrutinib, Obinutuzumab, and Venetoclax or BOVen in previously untreated patients with CLL. And just for background, we know that Venetoclax plus Obinutuzumab is a standard regimen used in the frontline setting in CLL and is associated with high rates of undetectable MRD. And there's a lot of interest in combining this regimen with a BTK inhibitor, and in particular with a second-generation BTK inhibitors on the basis of favorable safety in randomized controlled trials. And we previously presented and published the BOVen regimen in 2019, describing that this regimen was achieved the primary endpoint, the primary MRD endpoint, and was associated with high rates of undetectable MRD in these previously untreated patients. But we had an interesting study design, this MRD-driven treatment duration strategy, and so we needed longer-term follow-up to really evaluate the strategy. The design of the study was sort of unique, right? So previously untreated patients with CLL who required treatment per standard IWCLL guidelines were eligible, and they received between 8 and 24 months of treatment, where they started with a 2-month lead-in with the Zanubrutinib and Obinutuzumab doublet, and then Venetoclax was integrated starting on cycle 3, day 1. And starting 6 months into treatment, so after 4 months of the triplet, patients who were undetectable in the blood would have a confirmatory bone marrow within 14 days. If they were undetectable in both, they would have another peripheral blood MRD assessment. This was by flow cytometry at a threshold of 10 to the minus 4, defining undetectable. And if they were undetectable in both peripheral blood, two cycles apart, and also confirmed in the bone marrow, they were said to have achieved the primary endpoint and they stopped therapy. And so patients received between 8 and 24 cycles or 8 and 24 months of treatment, really driven by their MRD status, again, by flow cytometry at a threshold of 10 to the minus 4. And so this presentation includes 13 additional patients that were not included in the primary manuscript. The median follow-up at this point is 40 months. We have pretty good follow-up to assess the durability of their response and MRD response. It was a typical CLL population. The median age was 62. There was a 3-to-1 male predominance. About 3/4 were IGHV unmutated. About 17% harbored a p53 mutation or deletion. And so we treated these patients, and we found that treatment was, again, with long-term follow-up. We see no late unanticipated toxicities. We have confirmed that this is a well-tolerated regimen. The most frequent adverse events were things like thrombocytopenia, fatigue, neutropenia, diarrhea, bruising. But severe neutropenia, so grade 3 or 4, only occurred in 10% and 13% of patients respectively, and there was just one case of febrile neutropenia. So overall, this was really quite well tolerated. And in terms of the primary endpoint, so 96% or 48 of the 50 evaluable patients were undetectable in the peripheral blood by flow at a threshold of 10 to the minus 4. This using a 14-color flow assay. And 92% or 46 of the 50 patients were undetectable in both the peripheral blood and in the bone marrow. All of these patients achieved that primary endpoint with confirmatory peripheral blood testing and stopped therapy at a median of 10 months. So just 10 months of treatment with peripheral blood and bone marrow MRD undetectable responses of 96 and 92%. And so, the point of this presentation was really to focus on the long-term, the durability of these responses. And so what we found is that with 40 months median follow-up, that the median PFS is not reached. And the MRD-free survival, now this is really a time to event outcome that we don't often think about, but I think is really increasingly important in CLL, given so many effective therapies capable of inducing deep levels of MRD. And we really think is how we're going to really improve outcomes quicker, right? Given the association of MRD and progression-free survival, really, true clinical endpoints. But the median MRD-free survival at an MRD level of less than 10 to the minus 4 from end of treatment was 29.8 months in patients who achieved the primary endpoint and discontinued treatment of those 46 patients. One analysis that we thought was particularly interesting and that was included in this presentation was further analysis of delta MRD 400. So this is a measure of MRD kinetics, and it's measured in the peripheral blood using immunosequencing, and it's defined as a greater than 400-fold reduction in the MRD level from baseline to the cycle 5 day 1, all measured in the peripheral blood, again using the immunosequencing assay. And what we found previously is that if you achieved this rapid kinetics endpoint at cycle 5 day 1, all of those patients went on to achieve an early bone marrow undetectable MRD response, defined as within 8 months. The median time on therapy was just 8 months or 6 months of the triplet combination, and the median time to bone marrow uMRD was just 6 months. If you fail to achieve this rapid MRD kinetics measure, delta MRD 400 at cycle 5 day 1, you still were most likely to achieve an undetectable MRD response in the marrow, but it happened later. So among these patients, just 21% were within 8 months. The median time to bone marrow uMRD was 11 months, and the median time on therapy was 13 months. And this was really interesting in that it didn't seem to track with traditional risk factors. And so really suggests that this might represent a novel measure of risk. And what we found with long-term follow-up was that this was highly associated with MRD-free survival. So this delta MRD 400 identified a group of patients who had prolonged MRD-free survival despite a very short duration of therapy, 8 versus 13 months, highly significant difference in the duration of treatment. And yet, if you achieved delta MRD 400, the MRD-free survival was not reached, compared with those who failed to achieve delta MRD 400, the MRD-free survival was 18 months. And this really suggests that if you fail to achieve delta MRD 400, if you have a slower MRD kinetics using this assay, that maybe just simply giving 2 additional cycles beyond that first undetectable MRD response in the blood and the bone marrow is insufficient. Maybe we need to give more treatment. And so this really leads to the sort of the future directions, right? So we've recently opened a phase 2 trial of the same BOVen regimen, but with kinetics-driven therapy. So patients who achieve delta MRD 400 will receive 10 cycles of treatment. Patients who fail to achieve delta MRD 400 will receive 24 cycles of therapy. We're excited about this because, we hypothesize that the longer duration of therapy will further improve the uMRD duration for these patients who unfortunately had slower early MRD kinetics.